Welcome everyone to the 40th Annual Roger Johnson Memorial Lectureship. My name is Mimi Cabrera. I am the head of ophthalmology at Seattle Children's Hospital. I want to give special thanks to the organizers for this event, which are Christina McCambridge, Joanna Tuboy, Lachelle Chavez, and Jessica Steele. So today we're going to start with the Grand Rounds portion, which is for both pediatrics and ophthalmology. And we're going to hear from Dr. Galley on broad cancer impact from each child with retinoblastoma. Then we're going to have a 15-minute break, and then we'll reconvene for the ophthalmology only portion. But anyone else who's interested is welcome to stay. And we're going to hear about phase 1 sustained release topotecan chemoplaque for retinoblastoma. We'll have a 15-minute break, and then we'll end with digital retinoblastoma for full circle of care. And at 11:30, we're going to have a catered lunch across the hall from Wright Auditorium for those of you who can stay for that. So Dr. Roger Johnson passed away in 2007, and we are so fortunate to have Angie Corrales-Johnson, who has brought forward his legacy since then. Really, Dr. Johnson was a fixture of Seattle Children's. He was actually the only ophthalmologist here for many decades. And Angie tells me that his nickname was Mr. Muscles because he did so many strabismus surgeries. He also just really felt such a passion for helping children at this hospital, and this is the reason that he developed this lectureship. He wanted to give an opportunity to teach the community about pediatric ophthalmology, to allow us to come together, to exchange ideas, and also for us to come together with our shared love of serving children. I do have a very special announcement to make related to the lectureship. So thanks to the generous support of Angie Corrales-Johnson, we have a $40,000 gift to pediatric retina research in honor of the 40th anniversary of the Roger Johnson Lectureship. And this gift will go to a wonderful junior faculty clinician scientist here who does retinal genetics research, inherited retinal disease research, and research related to the topic of today, retinoblastoma. So please join me in congratulating Dr. Debarshi Mustafi. Come on up. All right, and so I really want to thank Angie Corrales-Johnson for her generosity for this donation and also for her wonderful partnership over the years with this lectureship. Angie is just such a kind-hearted individual and a wonderful person to work with. She also really has a genuine passion for helping people who suffer from retina disease, whether that be children or adults, as demonstrated through her immense generosity over the years to both Seattle Children's and the University of Washington. Thank you so much, Angie. So for the 40th anniversary, we wanted to go big this year and invite an internationally renowned speaker, Dr. Brenda Galley. Dr. Galley is professor of medical biophysics, molecular genetics, and ophthalmology at the University of Toronto. She directs the retinoblastoma program at the Hospital for Sick Children. She completed her MD at the Queen's University. She did her ophthalmology residency at the University of Toronto, and she completed her postgraduate training at Memorial Sloan Kettering. Dr. Galley's lab has been in operation since 1976, which is actually before I was born. And they have accomplished a great many things, including really being responsible for improving outcomes for children with retinoblastoma worldwide. They also have revealed fundamental mechanisms underpinning the molecular genetics of cancer in general. And Dr. Galley has also been part of the development of the 8th edition of the Tumor Node Metastasis, or TNM, staging system. She has also been recognized for her work by being appointed the prestigious Order of Canada, and she has also been given the Helen Keller Prize for Vision Research. So here at Seattle Children's, we do have a retinoblastoma referral center, and we have a multidisciplinary program led by Dr. Andrew Stacy, who's seated in the middle. So we and our community are really interested in hearing from Dr. Galley about innovations in the field, including her work on site-specific databases to improve global collaboration and treatment guidelines. So we're really honored to have her with us today. Please join me in welcoming our 40th annual Roger Johnson speaker, Dr. Brenda Galley.
I thank everyone. I've had a wonderful, very, very busy day yesterday with Andy, and I really congratulate you all on the work you're doing, and I'm going to learn much more about this afternoon. But I'd like to, in addition to thanking Roger Johnson for this amazing thing and for his career devoted to children, no matter what the circumstances around medicine, for this memorial lectureship. I'd like to introduce two other guests of honor here today, Marianne and Carl Bumke, and they are representing families with retinoblastoma that they have advocated for forever and bring forth great new knowledge. I'm going to talk about the broad impact, and Mimi's given my talk already. So I had to produce learning objectives, so every child is important, and that's really important for Roger Johnson. Systematic studies are really critical to find the hidden truths and dangers. And today we have to pause and say, what are we doing that's going to be wrong in 10 years or 1 year? And what could be game-changing? So you've all got that. You have to check all those things off through my talk, okay? So I was a resident at Sick Kids and called to emerge because a child there had a red eye and a immigration note that he had a cataract. He did have a red eye and maybe a cataract, but he really had bilateral retinoblastoma. And his metastatic tumor had spread all the way through his optic nerve, as you can see. Can you see, is my point, my little arrow works? Okay, so this is all the dark blue is retinoblastoma tumor. And so he was treated extensively in 1973 with radiation, enucleation of this eye, that's why there's pathology there, but irradiation for the tumors in the other eye and for his orbit, and horrible systemic chemotherapy. And then he died a year later. I don't think we would treat him that way today. I hope that the medical system would give him high-quality palliative care at home. But that wasn't happening. Everything was cure, cure, cure. So this picture is one, you can see it's a slide. I know you young people don't know what a slide is, but it's a little piece of film that you shine light through, and it's surrounded by cardboard. And so that, that's my writing there, December 73. At that time, I did, and you can see my signature there. It's quite the same today. And the date here is 1974, looking at his other eye that had one tumor here and one tumor there. And this is drawn on the standard retinal drawing paper that's still used in many parts of the US in retinoblastoma teams and a lot of the world to draw. And with colored pencils, retinoblastoma that's active is the code is yellow. It looks white, but you color it yellow to say that's active retinoblastoma. We don't use what we did for overlapped with our digital database for quite a few years, doing the paper drawings in our big, thick red charts. But then we now do only digital drawings in the database that my fabulous team at Princess Margaret Hospital across the street from Sick Kids built eCancer Care. And this was the first eCancer Care database was for retinoblastoma, but there's a whole lot of other eCancer Care, melanoma, lymphoma, and everything running in the UHN in the Princess Margaret because of copying this. And this is the drawing done there. You can see I did this just a few months ago, copying this drawing. We don't have any real good fundus pictures left over from that. And we published this whole series just recently in Canadian Journal of Ophthalmology because they had a little opportunity to get a paper in quickly, and we said, we need to get all this methodology out before we publish other things. So there it is, and this is this child's eCancer Care timeline. I'll show you some more, but you can see that this is the staging EUA, the red there. The yellow triangle, I'll point to that many times through my talk, means enucleation. And this black bar, we don't have many more examples, but that's death. So that was 1973. So I went to the hospital library, because I had to present citywide rounds like this, on this rare case of retinoblastoma. And I pulled off this newly published article, 1971, by Al Knudsen, where he showed that if you plot out the unilateral and bilateral on a semi-log plot, then the ones that only have one event required to get a retinoblastoma tumor are on a straight line, and the unilateral are more complex. There aren't very many patients here in this profoundly important paper, because that underpins the whole knowledge of genetics. So I said to myself, ooh, I think I want to work on retinoblastoma. And so I went to Memorial Sloan Kettering. In my interview to be a fellow there, the head of the institution said, why would you want to work on retinoblastoma? It's the only hereditary cancer. He was an immunologist. His immunology, he was right too. Immunology is really important in cancer now, but we didn't know that then. But he was wrong. Of course, the reason to work in retinoblastoma is because of rare, good things come out of rare. So cancer is a genetic disease and all that, and now we know that RB1 mutation detection can deliver precise care for children and families. And I'll talk a little bit more about that. So then this patient at age 11 had someone look in his eye, because I don't know why, because he had good vision in the eye, maybe a standard school test, I'm not sure, and found elevated white lesions. No clear diagnosis. These white things, lumps, could be von Hippel, could be tuberous sclerosis, or maybe spontaneous regression of retinoblastoma. Bob Ellsworth, because I was working with Bob Ellsworth and David Amos and Reese too. I even have a picture somewhere I can't find of all three of us, or four of us together, looked at this diagnosis, and Bob said maybe it's not failure, not spontaneous regression, maybe it's failure to progress. So I went to a really wonderful congress in Jerusalem in 1981, and I think I presented on our new idea of retinoma. And Roberta Pagan listened to my talk and caught me afterwards. And this is another slide taken in July 80, written on the cardboard rim. And she said, and we held it up to the lights, I said, could this be retinoma? And I said, absolutely, that's a retinoma. And we published that first paper, and then we tested the patient for the retinoblastoma gene and found that, in fact, there was an abnormal retinoblastoma gene in blood, and that led to the diagnosis of his second child having retinoblastoma because she carried the same mutation. And this is her picture of her eye in 94. This is her e-cancer care timeline. And remember, I said enucleation is the yellow triangle. She has no enucleation of either eye. She now has good vision in both eyes after a large amount of systemic chemotherapy and laser treatments. And this is just one little piece showing a normal fovea beside a scar. So I'll give you 2024 long-term follow-up on the patient who we diagnosed as retinoma a long time ago. And this are pictures taken now showing a collage of his, this is the one I showed you before, and the other that were always there that had not changed in all that time. And here's nice, beautiful imaging OCT done very recently, showing that it's quite uniform in its consistency, but it does have calcium in it, and all of which would say this is retinoblastoma, or retinoma. So my graduate student, Helen Damaris, had two parts to her thesis, but the main part is the molecular definition of retinoma. And so she took eyes that we had clinically said had retinoma underlying the retinoblastoma, but removed the eye. And then she microdissected this retinoma, retinoma, and retinoblastoma adjacent to it, and compared them and showed that the Retinoblastoma had lost both copies of the RB1 gene. The retinoma had lost both copies, and the retina was normal in this unilateral patient. So she showed, therefore, that loss of RB1 induces non-proliferative retinoma. And then she went on to show that this does cause increased genomic instability, which then goes on to retinoblastoma. So this is looking at the copy number, the chromosomal copy number across here, and normal is 2 copies of every chromosome, and this is the signal intensity in these 3 samples that she microdissected out of the eye. And you can see that there's only a few little errors which are kind of like normal out beyond the 2 copy in retina, but in the retinoma, you start to have signals going out beyond with different at 3 and 4 copy numbers. And going further than that into the retinoblastoma, you see, and these are the genes that are represented by these colored peaks, then we'll see that 6, the only one really that gets out to 6 copies is chromosome 6p. Jump from, this is 2008, jump to 2021, when Jesse Berry's team and others around the world have shown that by taking a sample of fluid from the aqueous humor, you would be able to know what the copy number change pattern is in the tumor at the back of the eye. You don't need to enucleate the eye, and you don't need to enucleate the eye at all to do this. But the key thing here is 6p. This is actually at probably MICN, which is another equivalent of genes that amplify or have severe amplification or gain that relate to progression to the need to enucleate. And so here we are back at this retinoma, defined as that. Nucleated tumors have 6p gain, and now we can determine that before the eye is enucleated. But that's all studies that are underway with global collaboration led by Jesse Berry. But this paper, 1984, with another PhD student in my lab, showed that a special form of 6p had 60% of tumors that enucleated. So that really correlated with gain. So I ask, here's the 6p, here's the 6p, and I ask, what's the 6p copy number in this retinoma? Because could it be normal? Could that be why this has been so stable over a long time? It doesn't have those other changes that are key to cause progression to full-blown retinoblastoma. By the way, I'd love questions at any time. Have any questions on this? Don't hesitate to jump up and down and say, I'm wrong, okay? But we'll jump forward to the TNM 8th edition, which Mimi's introduced already. And the lead author is Malapatna, Ashwin Malapatna, who was on the Teams meeting this morning at 5:30, which I was joining remotely, virtually, discussing all our patients. Ashwin is now the head of the retinoblastoma program at Sick Kids and is joined with Stephanie Kletke, also very, very well trained in retinoblastoma. So there's 2 of them. And I'm still on staff because when they all go away or get sick, then I fill in and I can still do some things. But I'd rather be focusing on the research I'm talking about here. So the data behind this figure, which is looking at the new staging, 2017, and it's based on a study we did collecting information from around the world on all these 1,700 eyes between the intervals of 2001 and 11. So that's a window bracket that we were able to go through, poll the world. The major contribution to that was John Chow in China, who sees more patients than anybody else in the whole world as one person traveling from city to city to city. And I followed him and gone to the OR with him many times. Amazing person. But he contributed most of the data to this. But that's real data. And if I find in looking at that database, because that database is at Princess Margaret, and I'd say, something doesn't make sense. I can't, there must be something wrong. And I would phone him and he'd be in an airport somewhere about to get in a plane. I'd say, the date on this patient, something must be wrong because these don't add up. And he'd say, wait a minute, and he'd go to his iPad, and he had the whole database in his iPad. And he would say, yeah, the real date of that event is X. And we'd fix it, and that fixed the whole problem. So an amazing, amazing person. So out of this 8th edition, these are just the distribution of stage of eyes, but we defined, Ashwin and I had a big fight with the American Joint Cancer Commission that hereditary had something to do with prognosis, and they said, okay, we'll let retinoblastoma have the H in the staging officially as a trial, because we don't really think heredity is involved in cancer. Back to applying for a fellowship in New York. But this is now 2017. So we succeeded, and the definition, and I'm going to quiz you later, do you all know what H means? HX means you don't know anything about that patient, so you can't tell. H1 means they are bilateral, trilateral, family history, or proven molecularly to have an RB1 pathogenic allele. H0 is if you do not have the infant or the person does not have the abnormal allele of their relative, then they are H0. But if we're testing the blood of a parent of the H1 child, and we don't find it, we don't call them H0, we call them H0 asterisk, because there's a less than 1% chance that they're mosaic, at which point their baby could be full-blown H1. So we still attach that. So now you know everything about H, right? Any questions on that? You all knew this already. So positive RB1 test facilitates in Canada early delivery so that we can treat tumors, but not in the States. Why? I think you know the answer. Some of you do. Because the obstetricians say, we can't deliver a normal baby early. And I say, but the baby's H1. At 36 weeks gestation, 30% chance there'll be tumors that will be threatening vision in that eye, in either eye, or both. And they still won't let the legal system deliver a baby early. But in Canada, this is a family, for example, that the grandmother had both eyes removed and did die of a sarcoma, but at advanced age. Her daughter had retinoblastoma, and I treated her with systemic chemotherapy and focal therapy, laser cryo. Her other child was H0, proven to not have the mutation of the grandmother and the mother and the sibling. And then she had first child, no mutation, didn't touch that pregnancy, everything normal because didn't need anything. And then the second child was found by amniocentesis to be H1. And so that baby was delivered early. And here she is at 15 days. That took 15 days to get to Toronto. The baby was then 38 weeks gestation age. And we could not see any tumors here. But when we do the OCT, which we do in every quadrant around and carefully on all these babies, with them bundled up in the clinic, sedated with sugar water, and it works great. And there's a tumor in the internuclear layer of the retina. So we can't see that, so we want to laser it, but we don't know where it is, so we have to follow the vessels and say we think it's there, and then we put in one laser burn here, and if we hit it right, then we now have a laser mark in the retina, so then we can continue treating. And so we put one burn in, and if we're offset a little bit, then we would know where to go. And then at age 6 months, here's the scar from these laser treatment of this, and the fovea is there. And this is her at 11 years. She's actually beyond that now. She's probably 14 now or more. And here's the OCT across the scar and the fovea, and she has 20/20 vision. So recent Ellsworth very smartly said years ago in their 69 paper, which defined the Ellsworth staging for retinoblastoma, when a decision is made to treat more advanced intraocular cancer, it's obvious that some type of quantitative scheme was necessary. But that was not implemented. It's a really smart idea. The staging did work, but it wasn't until 1997 that this radiation risk to increase second cancers in H1 people was recognized, because there was no clinical trial. No one was monitoring them. And I could see it when I was in New York. I went to every single EUA day. I was at Memorial Sloan Kettering, but I went up to Columbia on the subway to see everything that was happening. And I could see in seeing the patients in the clinic, that a lot of them were having second cancers, but it was never measured. So it's very significant for being H1 compared to H0. But if you add external beam radiation to their treatment, which I was responsible for irradiating a lot of patients in the 70s, early 70s, because we saved eyes, we saved vision at a significant price of increasing this risk. If they didn't get any radiation, their risk of a second cancer is much less. So here's another family. This is, again, a bilaterally enucleated mother. I talked to her on the phone a few weeks ago. She had a full-time job and still very active and busy with no eyes. She had 4 children. All of those children had bilateral retinoblastoma, and I eagerly in the 70s irradiated them. All of them had external beam radiation, except this one only had one eye irradiated. The other eye treated with laser, etc. These 2 have already died of their second cancer. This father is quite concerned about his second cancer risk, and we have to go back to Princess Margaret, dig out his records of what kind of radiation did he have and what should be done about that, but we still can't activate much of a team to put surveillance for these radiated H1 people high on the list. So that's still a problem for everybody, including the gene team in retinoblastoma here, to work on solving that problem. So his first child was H0 and his third child was H0, but his middle one was H1. And you can see by this logo that she was treated with focal therapy, and then she had the chemoplaque, which I'm going to talk about in a minute. The youngest one is H1, bilaterally irradiated, and wants to have children. Hasn't done that yet, and is quite concerned about everything. But we will deliver that baby early. And in Canada, I don't know if I said this already, but the babies, if a pregnancy has an H1 baby, they travel to Mount Sinai Hospital across the street from Sick Kids to deliver the baby, so that we can see the baby coming through the tunnel with all its nurses and everything. They're not premature, they're just early term, and we can start looking at the eyes, and we do that examination every day for a week or so. Then they go home, and we still keep following them. So I did talk about eCancer Care, this database. I showed you a couple of timelines on that. We actually installed eCancer Care in the University of Nairobi IT servers. And the ophthalmologists there, who are a fantastic team in retinoblastoma led by Kahaki Kimani, would put all the data on the children every time they saw them into eCancer Care. And then we'd get a call, Justin Liu, who is really responsible for making it work. Yes?
Yeah, so I have a question.
Good.
So if you go back to your, like the survival, the H0s and the H1s.
Yeah.
Now, like you went over to the far right, so that the H0s,
The H0s are truly normal people. Normal.
Now, what about the mosaics? Will they have like an intermediate?
It depends on the level of mosaicism, maybe, but it's not well studied. But they have got a definite risk that their baby could be conceived by the chromosome, with carrying the chromosome that is 1% or 10%. Most of the mosaics are that we can identify by testing blood of the parent are in the order of 25 to 50% mosaicism.
Just follow them regularly, like the H1s?
The H0s we follow regularly. No, but they're not H1, no. So as a child who's shown to be mosaic, we would follow them, but not like we do in H1. Okay, but it might depend on the level of mosaicism. I'm not sure. It would depend on a team discussion to decide what they wanted to do.
Just the other question, like, how did Canada pick, like, okay, it's like 36 weeks? You decide at that point.
It's not premature.
Right. Well, no, I always think like.
And when we did it, and Sammy Solomon, who's going to start at BC Children's soon, he did a really nice study of all of them, and there's other studies too that show that the tumors at 36 weeks arising in their eyes are vision threatening because they're at the posterior pole, and 30% will already have a tumor at 36 weeks. So that's how we picked it. And of course, we don't always hit that. It may end up being 35 weeks, and maybe the baby will be born at 30 weeks because other factors. But we don't let them go past 36 weeks if we can. Okay, thank you. So here we are. This is Depict Health. When we had this server in Kenya, and we'd get called by Kahaki, it's not working, I can't get into e-cancer care. We would figure out that the power was off, or there was a power failure at the university, or there was a strike or something, and the machine wasn't turned on. So we said, we can't get this to the world this way. So we have to go on the Azure cloud. We have to go on the cloud, and we are now on Azure cloud, to be able to deliver timelines to the world for retinoblastoma. So this is actually built in Depict Health. This was built in using a demo, which is not running anymore because we're so close to going truly live, and everything's moving around in these Azure workspaces with all the firewalls and all that. And they said, we got to take down the demo. Sorry, there'll be another demo up sometime soon, but because we're almost ready to launch. But here is the bottom line. Here you can see the same yellow triangle for enucleation. So you now know that this kid had left eye enucleated after 5 chemotherapies, and this symbol would take you straight to the pathology for the digital pathology of the whole eye, enucleated eye. And the other eye had intraarterial chemo, and then at this point, after 7 cycles of systemic chemo and 2 intraarterial chemo, looks like this. This is the primary tumor right there beside the nerve, this with this, but it's now caused a retinal detachment. So his vision's abruptly changed, and that brought him to attention at this moment. This is just a picture of one of these tumors way out here. What would you do? It's his last eye, enucleate or external beam radiation. So I went to a World Congress in Barcelona, had coffee with Lynn Murphy, who was the guru of retinoblastoma in LA for many, many, many years. And he said, that thing I've been working on for a long time, FDA has given me a permission to put it in a human. And I said, I have the patient. So I came home and I spent my full week arguing with Health Canada that a little silicone thing with a little tiny bit of drug in it that you could take out at any point if it caused any trouble wasn't dangerous. And they finally let me put in the first topotecan chemoplaque, which is sitting right here. This is, you actually fasten it to sclera. This is the yellow topotecan in it. I have one in my backpack, and you can see it afterwards. I should have brought it up here, but it doesn't matter. And you have to glue it to the globe, no needles, no sutures near eyes with retinoblastoma, including in enucleation of a retinoblastoma eye. We cut the muscles and we let them fall back because we don't want a suture near the eye, because we've seen and experienced it once, long, long time ago, when we hear of a kid who's now got orbital recurrence, and we go back to the pathology, and there was a needle track, particularly the lateral rectus, which is very thin there. So we just cut the muscles and let them go, and it's a beautiful way to do a myoconjunctival enucleation, which I don't know how you do your enucleation. I haven't heard. I need to learn more about that here from you guys. So at that point, we put that in. We left it in him for a long time, 70 days, because we didn't know and it wasn't causing any particular problem. And today, he's out at close to 5 years follow-up with 20/40 vision. We did not cure this tumor attached to the calcium. So then he had another procedure. He had cataracts and procedures. And then we followed John Chow from China's tylectomy, and we removed this surgically. And he has now a good vision, and there's his nerve, and this is now the flat scar, and all of this stuff's gone by surgically removing it. So then Health Canada said, you can't do more of those. We did 3. The others were didn't have such good results because they were probably too bad already. And this is the study we did because Health Canada said we must do it. So it's combined now between Sick Kids and Phoenix, where Aparna joined us later with the identical protocol. At Sick Kids, we used doses 6 to 1.2, and Aparna started at 1.2 because we'd already done these, and that was really good because there was a lot of toxicity at these higher doses, and I'm glad she did that for me. We leave it in for 6 weeks, and we follow officially in the clinical trial to week 9, and then we follow them up for 3 years. So this is another an undergraduate student from a small university in Quebec said, we'd like to take that timeline and compare timelines between patients. And she built in Excel this amazing database that drives this swimmer plot. So the only data you put in Excel is a date and an event. And you can see these are the events, all the treatment events we have today. Chemoplaque's not on there because it hadn't been invented when she built this. And then the database pumps out all the patients that you've put in. And you can see one of our patients here has got a very, very long timeline, as does this one who's out at 6 years. This is a much older patient. And time 0 here is when the chemoplaque went in. It's a definitive point in time, the date. And Isabella, who built this, is now about to finish medicine at University of Toronto. But in the meantime, when I would take her Excel and I'd add a new date, I'd do something, I'd break it and it wouldn't work. And I would email it to her, and within half an hour, no matter what she was doing, she'd send it back to me fixed. Then I found a wonderful person, who I'll show you a picture of him somewhere here, who is an engineer from Hong Kong who had left Hong Kong and came to Canada as a refugee when China took over Hong Kong. And he is responsible for this, and I can text him or email him or phone him and say, could you give me a fix on this or add this new data or update the follow-up? Because here's 3 years, and if we hadn't printed this out in my slides, I'd be out of date, and he gets that back to me. Wonderful, wonderful people. So you can see the different doses here. You can see all the things that happened. The other thing we invented, rather than RECIST, which is a standard way to look at outcome in clinical trials for cancers, but we said which defines, and Jessie Berry's the lead on an author that I'm a co-author on a few years ago, of a RECIST for retinoblastoma involving ultrasound, this and that, and how measurements, and what are you going to measure, and it has to shrink by so much. You can't do that in an eye full of retinoblastoma that's popping up all over the place. You can't possibly do that. So we invented a new outcome measure to get to complete response. If there's no treatments after your intervention, is that me beeping? Is that somebody else? Something's beeping. Oh, I have a pointer here too, but I'll keep pointing like I am, if that's all right. This is the chemoplaque, and where there's a CR, complete response, there's been no other treatment. We have got one that was a CR here along this line till very recently, and at 1.8 years had a single recurrence treated with laser. So that's no longer a CR on this patient. And you can see that, I'll come to it in a minute. And then we put dose-limiting toxicities, and the only dose-limiting toxicity for any of them, including the high doses, is scleritis. One of these primaries, which I'm not going to show you the details of it, gave us we took it out at week 9 because it was a huge tumor touching the lens and really too extreme for the chemoplaque, but we put in 1.2 chemoplaques in that eye, and then it recurred, and then we enucleated, giving us the advantage of having pathology showing the scleritis. And in all of them, they have a footprint scar from it. But the severity of the scleritis/uveitis depends on the definition of severities, whether it's dose-limiting or not. And we have to follow all the clinical trial rules for reporting everything like that. So that comes up with a recommended phase 2 dose, and of 2 doses, the 0.9 and the 1.2, which much of my slides are dealing with that. We now have decided, because now we've discovered there's a dose-limiting toxicity we hadn't recognized as such, so that means that really it's the 0.9 is what's going forward, but I'll have both of them in my analysis because this is all new thoughts from last week. And there's a primary. There only were 2 primaries, one I described, but this one I'll show you because this was her macular tumor. This child should have been recognized to be H1, should have been delivered at 36 weeks, but between health things and nobody really listening to parents, it was revealed that the father of the patient we were treating in Toronto was an identical twin of her cousin. And only did we realize there was a problem, or that even was a fact, until we were seeing the first patient in Toronto in follow-up as an H1 with one eye enucleated. And they showed us a photograph that their sister-in-law had just sent with leukocoria. And that's this child. And the leukocoria was a reflection off that tumor in her fovea. There's her foveal pigment showing where her fovea is. So here she is at week 2 with the chemoplaque. It's the only picture I have with the chemoplaque actually showing, but because you don't normally get that right angle in your ultrasounds. Or UBM. This is the footprint of the chemoplaque. She had 1.9. It's left in for 40 days, and it's a range around 42 because you can't always get the OR on day 42. So we take what we can get. This represents the scleritis here, and the green circle shows the area of the footprint. And here you can see on this OCT line across the calcium there, which is shown here, that there was a little tumor in front, so this is still active at week 9. But we didn't do anything because it was early. And now from week 35 till now 3.3 years follow-up, it looks the same as this. And there's that little bridge still sitting right across that calcified area. Her vision is fix and follow in this eye, as you'd expect, because when we measure vision in children and adults, we ask them to read. We don't do a visual field, and this child shows we should do more than fix and follow. Here she is, complete response, and I got an email on the weekend from her mother. Here she is. I have permission to use her real name in this real picture. She starts Head Start. But she'd been told by an ophthalmologist who saw her in follow-up, said, her vision will never improve. It can't improve. There's no point continuing her patching. But her mother said, but she runs around. She does everything with her patch on. She's great with patching. So what should I do? And my answer is keep patching for the rest of her life because she has really important functional retina. This is why she doesn't trip. This is why she can run around, maybe even catch balls, because she's so smart with her patch on. So now she'll be patched, okay? And that's why fix and follow is, we should do more than that somehow, but I don't know what that will be. I'll leave it to you guys. So this is the chemoplaque results, combining the 0.9, so at our, and the 1.2 dose. 0.9 would be for kids under 6 months, and 1.2 for over 6 months. It's only age dependent, because putting 2 chemoplaques on a smaller eye is harder, or not so useful. And then we figured out that we had this beautiful curve of a nice thing, but we needed to have controls. So we went back to our eCancer Care database, and I'll tell more about that, but this is our matched retrospective controls. And it shows that the chemoplaque's quite a lot better by this analysis. And here's the data, the chemoplaque combined sick kids and Phoenix data, and you can count all the numbers, and 0.9 is 75% complete response, and that's our current new going forward. If we look at, this is all of them, including enucleated, 8% enucleated for any reason. We count any time there's a yellow triangle in Depict Health or any cancer care. That means enucleation. We don't need to justify why that was done. And then we pulled out of our retrospective controls from 2017 to 22, because that's a kind of a time window when the same treatment options would be available as for the chemoplaque patients. And we pulled out the retrospective controls, and with 3 cycles of IAC or 4, that's the best results for complete response, and it's 13-17 versus 75%. And then looking at enucleation, which we haven't done much about this, but it will be in our publication, that the enucleation rate was higher in these two, enucleation for any reason. So forecasting retinoblastoma of cases I'm sorry the data's back to 2016, because I didn't have time to go back and update that, and it's always out of date because it's based on global figures, and the global publication of events like retinoblastoma frequency is always several years back before they can figure out how to do it. But there is more data, but it's not much different. Canada has only 23 a year. The U.S. I don't have, oh yeah, there you are. And I think it's probably 250 or something by other, like SEER and different things now would say 250 a year, compared to India, which is the lead in the world, more even than China, because more babies are born in India. So we discovered, how's my time? Am I over time?
10 minutes.
Good, okay. So I won't go into the epidemic in Alberta. You can ask me questions later. Why would there be an epidemic in Alberta? It's very interesting. So here's Depict Health. This is designed, well, first of all, Sick Kids said, when we were just about, the head lawyer was really keen on this idea till he thought hard about it, and then he said, we can't be responsible for Depict Health. You're going to have global patients in there. Sick Kids is responsible for Ontario, maybe Canada, but not the world. And so we took Depict Health out and formed a charity, the International Retinoblastoma Consortium, and we now pay $5,000 a year from the charity to the University Health Network, Princess Margaret Hospital, for the database I built. We have an exclusive license for Depict Health, and so because they own it. But the charity has now built and paid for the secure access and the Azure cloud positioning. So now it's really interesting. All those other databases that are built on eCancer Care, following us from 2000 onward, inside Princess Margaret, if they want to use Depict, they're going to have to pay our charity for the secure access package. Does that sound like a business model? Maybe. So the family can view only the data, but the clinical team enter the data. Anyone, and I probably don't have everybody involved there. And each site, like Sick Kids is a site, Alberta Children's Hospital is a second site. The patient family they participate by signing a communication consent. And we tell the site, and in the legal agreement to allow us to do this, the Depict Health is not custodian of any data. It's a communication service. It's minimalist data to be able to communicate outcomes in retinoblastoma. The institution, the site, remains custodian of the data. And we hope that they all will agree with that. Alberta Health is one site, the whole province, which is really nice. And so that will probably be where we'll launch first. And then we'll be coming here and asking your children's hospital to join Depict Health with agreeing to do it, and then any of your patients would have to sign this communication consent to become a site. Then we ask for an optional research consent. They won't get into the database at all without this communication consent, but they don't have to sign the research consent. But if they do, coded and aggregate data from Depict Health will be all organized for them and given back to the site. So we're not stealing their data, we're giving it back to them in a research-ready format to do whatever you want to do with your patient's data. We also take that data and take it outside, and we now take that through the Pediatric Data Commons, which I'll talk about more in my third talk today. and so we don't have to build all this pathway to get secure evidence, and it'll go back to them there. So this is everything I've talked about. Here's Depict Health at the end, and here is external beam radiation in the 50s when the indirect ophthalmoscope was invented, and here is my Knudsen, 2017, my first patient. I call it patient one. And this is all the H1 staging. EBRT lasted until 97 when systemic chemotherapy was finally agreed it could be used for retinoblastoma. And this is H1 early delivery with OCT-guided treatment and the chemoplaque, which I'll talk about in my second talk today for anyone who wants more details. So can you all answer this? I don't know in these official learning objectives. Do you guys all have to check it off in a box that you've actually paid attention? I don't know. Anyway, I think we can say what we did do, and I did this to many patients to irradiate them to save vision and eyes, was wrong. But we couldn't know that at the time. And maybe the chemoplaque is game-changing, maybe.
Thank you so much, Dr. Galley. We do have a few minutes for questions, or if people want to put questions in the chat.
I love questions.
Great. Yeah, well, thank you so much for that talk. Really amazing work. I just have a quick question about some of the early data you showed with the copy number changes from the aqueous biopsies. Is it thought that those copy numbers are coming from essentially cancer cells in the aqueous humor? Or is this like cell-free DNA that's being picked up?
It's cell-free DNA that is only really released by cancer cells in the eye. There's no cell-free DNA in the anterior chamber in a normal eye, as far as I know. So you get 0 on even having anything to test. But when you test that, the copy number changes are there. The RB1, both alleles are gone in that cell-free DNA you sample from so you can diagnose and you can know how severe it is. And I would suggest that if there's a 6P gain, that would say you better hurry up and treat because there's a higher chance you'll fail to save the eye.
Excellent talk.
Thank you.
How many American babies whose parents are, H1 or whatever you would say, and you do amniocentesis and the baby is found to have this genetic predisposition, how many are going to Canada for early delivery?
I don't know that any are coming to Canada for early delivery, but one of our patients who we treated and was determined she was going to get an early delivery for her baby, she went to Boston and argued through the whole thing, and the baby's good, had tumors at 36 weeks, treated with laser only.
India or China?
No, I don't, not that I know of, and I haven't had the strength to go further on that. What we are doing is and using analyzing it by our new propensity matching of retrospective controls, going back to all our already published patients, and all the new ones since then. So a bigger sample size, and we will hope that that will maybe influence. I mean, to me, the obstetrician should be sued by not delivering early when the child is H1.
I would like to shout out to the family that went to Boston and argued for their child's best interest.
Yes, yes. But we're so rare in retinoblastoma, no one wants to pay any attention to us.